This is just kind of a short, we could talk about transplant forever. So this is sort of a short beginning to the discussion. We'll kind of talk about it. So again, it's an abbreviated history. We'll talk about why we do it, but what the risks are and some of the mitigating procedures to decrease risk. So interestingly, in 1988, the first successful stem cell transplant for sickle cell disease was reported. What's most interesting, it was actually a child who had leukemia. She had AML and underwent a stem cell transplant for her leukemia, which sort of, it was somehow not expected, but cured her sickle cell as well. And then they realized, of course, that stem cells, if you replace them with healthy stem cells that make non-sickle hemoglobin, that would work. So transplant trials started really being conducted right after that. My friend Mark Walters and colleagues published the very first so-called large series of stem cell transplant for children. And that was 22 kids with what they called severe sickle cell disease. And for the most part, that meant a history of stroke or a history of acute chest or splenic sequestration. Vaso-occlusive crises was one way of allowing entry into the trial, but a lot of these children had stroke. And 90% were alive at 2 years of follow-up, which is really the first sort of assessment post-transplant. And 72% at that time had stable chimerism. What does chimerism mean? Well, when we transplant someone, we're replacing their bone marrow with somebody else's in the case of an allo transplant. Allo means other, it means you get it from somebody else. So in this scenario, you're giving someone matched donor, because these were all matched donor, all from a sibling. And then we measure what we call chimerism, which is how much of the stem cells remain the patient's versus the donor. So we say the patient becomes the recipient, the donor is the matched sibling, and our goal is 100% donor, but we don't always get there. And there are several papers that have now demonstrated that you can have a mixed chimerism, where you might be half donor, half recipient, and that can still cure sickle cell. So you'll often hear us talk about chimerism. That being said, 100% donor is always best. Now, 18% had graft rejection. That means that they kicked out that new marrow. They said, this is not mine, I don't want it. And their own stem cells regrew. And there were several neurologic events that included seizures and cerebral hemorrhage. And that was in 7 kids. And we're going to talk more about that. So then another trial that was published around the same time reported on 50 patients who'd received matched sibling transplant. And they used the same chemotherapy, which is conditioning regimen, as the first group, busulfan and cyclophosphamide. But then they added either total lymphocyte irradiation or another drug called ATG. And so they had 2 groups in this trial. 36 patients had what they called severe sickle cell, and then 14 that had asymptomatic disease. And the median age was young at 7.5. They transplanted one of these children at 9 months of age, which was fairly shocking. And survival was 93%. They did see acute graft versus host disease in 20 patients, which is a lot. That's significant, almost 50%. And 1 patient developed acute leukemia. So what is graft versus host disease? That's when the donor, the new bone marrow, recognizes the recipient or patient as abnormal and attacks it. And it tends to be gut or skin or liver. And it's one of our worst fears as we take individuals with sickle cell to transplant, is that we'll take away their sickle cell and give them graft versus host disease, which has its own set of complications and risk for morbidity and mortality. However, they saw less graft rejection in this group. So then Walters et al. Had published an additional 50 patients. And remember, originally they had almost 20% rejection. So here they added, they did the same conditioning of busulfan and cyclophosphamide, but then added ATG, or a different drug called alemtuzumab. This median age was a little bit older, at about 10 years of age. Overall survival was 94% and event-free survival at 84%. But they saw a lot less graft rejection. So they were able to get the new stem cells in there. They still saw some of these significant cerebral issues, and one patient died with an intracranial hemorrhage, and 2 died from complications of graft versus host disease. So then we move onward and we're continuing to improve things. And now this is a trial that was published in 2007 by the CIBMTR. The CIBMTR is the data repository, kind of a registry for all people who get a transplant of bone marrow. And now they had 67 children. And what you can see is the acute graft versus host has gone down from some of those earlier trials now to only 10%, although we were still seeing a lot of chronic graft versus host disease at 22%. It wasn't causing morbidity. And the majority of these children were alive after 3 years and doing well. 55 patients remained free of sickle cell symptoms, and their S level stayed low. But again, we saw this problem with neurocognitive or neurologic, not neurocognitive, neurologic issues in which 11 patients had seizures in that first 100 days. So we still needed to make some significant adjustments. So then the French came in, and the French have done some of the very best work in transplant. If you ever come to a meeting in sickle cell disease, you'll recognize Dr. Bernardin across the room. I'm not sure how old she is, but she's really done amazing work. She's very French, and she has very bright red hair, like very bright, like dyed red hair. She's easily 70 if she's a day. But she always has red hair, so you can always find her. But what she did was really focused on the kids who'd had neurologic complications. And she's able to have a lot of kids with matched siblings. And of interest, she's in Paris, but many families come from Africa to Paris to be transplanted. And in case you're wondering, if you ever felt like moving to France, once you live there for 3 months, you get health insurance. It's free. It's part of just being a French citizen. And all you have to do is establish residency for 3 months. So on that note, she added the ATG that I mentioned before after the cyclophosphamide and busulfan, because again, in those first 12 cases, 30% rejected. Once adding ATG, the rate of graft failure was 3%, and overall survival was 93% at 6 years. So what did this group do a little bit better? Well, they did a couple of things. One of them was those neurologic complications that we just talked about. And we talk about these a lot, especially with our adult bone marrow transplant colleagues, because the risk of neurologic complications is much higher in sickle cell when they undergo transplant. So here they started clonazepam at day -8 because they recognized there was a significant increased risk of seizure. And what we know is the anti-rejection medications, all of them, cyclosporin, tacrolimus, sirolimus, all the ones we use, cause some of those problems. So they put them on clonazepam as seizure prevention, and that really improved those seizure rates. They also recognized that one of the big problems was arterial hypertension. Most people with severe sickle cell disease or hemoglobin SS disease, their normal blood pressure is about 110/70. So when they get blood pressures of 130/90, they can have what we call PRES, and we'll talk about that another time. But suffice to say, it's bad. And so we now know we have to keep very, very tight control of blood pressures. And it's very hard for our adult colleagues to recognize this because they think 130/90, no big deal. But it turns out it is a big deal in this group of patients. They also kept the hemoglobins a little bit higher, and importantly, kept platelet counts higher. So when we're doing a stem cell transplant, we give chemotherapy. We talked about that. And that's because we want to empty out the bone marrow. And if you don't empty it out, it's harder to get a new bone marrow in. It's like trying to fill up a cup that's already full. But when you empty out the bone marrow, not only do you remove the stem cells, but it means that for a couple of weeks until new bone marrow comes in, those patients can't make white blood cells or hemoglobin or platelets. And so their platelet counts get very low. And for the normal transplant patient, we only worry about keeping their platelet counts greater than 10, because once you get under 10 is where you have an increased risk for spontaneous hemorrhage. But we realized in the group with sickle cell disease, their risk of hemorrhage was higher. So now we keep all their platelet counts greater than 50. And that's also something different than in the average or regular non-sickle cell transplant. So what are the things they did kind of in recapping to really mitigate risk? Adding in anti-seizure therapy, keeping a higher hemoglobin, which improved the blood flow to the brain, higher platelet count to decrease that risk of intracranial bleeding, and significant tight blood pressure control, and that reduced the risk of intracranial hemorrhage. And so we started asking more questions, right? We knew how to fix it, but what was causing it was the question. Well, there's a couple of reasons you get neurotoxicity. Busulfan, the chemotherapy that we continue to use now, is actually neurotoxic to everyone. And now in anyone who undergoes transplant, they start anti-seizure therapy 24 hours before starting busulfan. And the other thing we do now is actually check busulfan levels very, very closely, because we've learned that they're very individualized. But even after we fixed that, we saw that people with sickle cell remained at risk. And that was especially of this intracranial hemorrhage, which of course just is terrifying. We were seeing this as patients even got a little bit older, in young adults, which is also when we see the risk of intracranial hemorrhage without sickle cell disease. And we found that one of the big reasons for this was increased blood pressure. When you have an increased blood pressure, normally your blood vessels know what to do, and they auto-regulate your blood pressure by dilating. But because of all of the damage the blood vessels have had from sickle cell disease and the unavailability of nitric oxide, which we've talked about before, the blood vessels just don't respond appropriately. And so we've seen that that's one of the biggest problems, which is why we want to keep them on the slightly hypotensive side. We also see small aneurysms, and we are looking more and more about these aneurysms in our adults, trying to figure out, how do we screen for them? Do we screen for them, and when do we treat them? But in the group that would go to transplant, you can imagine aneurysms have very thin walls, so the blood vessels are abnormal there. And that even puts them at higher risk of one of those bursting. They also could get blood clots in the venous system of the brain, and that could cause thrombosis, which would increase pressure. And then we also started to worry about moya moya, because we already know when people create these extra blood vessels in their brain called moya moya, that those blood vessels are also quite fragile. So all of these things together are what we try to control for and recognize, so that we can prevent these complications. So when we think about the hemodynamics, and we think about adults with atherosclerosis, right? Anybody who's enjoyed too much McDonald's over the years, again, they have an automatic auto-regulatory response. So if they were to have a stroke, the brain responds appropriately and will decrease perfusion to that area. And if the perfusion pressure decreases more than can be compensated, we have something called, our body says, oh, we need more oxygen. And so we increase our oxygen extraction fraction. We're going to talk about all this later, because it's very, very complicated, but really important in sickle cell disease. And so basically, if there's lack of blood flow, the body says, I need extra. So it dilates the blood vessel and increases the oxygen extraction fraction, meaning it takes more oxygen out of every red cell to it. And our body works for as much as possible to keep our brain getting oxygen. But if all of that doesn't work, that's when you get a stroke. But in people with sickle cell disease, they already have increased blood flow to the brain because their body's already compensating. They already have this increase in oxygen extraction because of their anemia and the poor carrying capacity of the red cell. And so they don't have as much room, if an insult occurs, to appropriately respond. They don't have these normal hemodynamic responses, which is what was causing all these issues. So we also have a syndrome called PRESS that we see in transplant, but we see it out of transplant as well. It is called posterior reversible encephalopathy syndrome, and we've unfortunately had a few patients who've experienced this. And it's this neurotoxic state, and to be honest, we don't 100% understand why it happens, but we know a big part of this is really quick blood pressure changes, where you get sudden onset hypertension. And so that's why we see it in the allogeneic bone marrow setting. Interestingly, people who are pregnant and have bad preeclampsia or eclampsia are also at risk for this in sickle cell, and a few other disorders that can significantly increase blood pressure. Now, it tends to happen if you go from normal to high blood pressure very, very quickly. So if we have some of our sort of regular hypertensive patients who slowly increase their blood pressure, they're unlikely to have this complication. But they get really bad edema at the back of the brain. They get encephalopathic, and it needs to be addressed right away by decreasing blood pressure and a few other things. And by doing that, you can actually get them to return to normal, but it's a terrifying experience, and they often have seizures. Um, we're not going to talk much about press right now. We'll go back to that another time just because it's its own conversation. But this is just some other data that is older. It's from the 1990s, but again, looks at blood pressures and noticing the difference between individuals who are, quote, normal compared to those with SS and SC disease. On the left is males, on the right is females. And you can see that bottom line on this graph are people with SS disease. So they have their normal blood pressure is 110 over about 55. And sometimes as much as even in our 20-year-olds, you can see right here, if you look at a 20-year-old female, they may have a systolic blood pressure of 110 and a diastolic of 65, but they can be in a normal range down to 50. So people get anxious when our patients' blood pressures are 100 over 50, and they're like, oh no, they're hypotensive, but it actually may be normal for them. This is looking a little bit more at blood pressures, and we're going to skip that for now. So we've talked about some of this impaired dynamic cerebral vascular autoregulation, and that's a lot of what is actually causing the cerebral vascular changes and the risk of stroke in the sickle cell setting. And it's something we see even outside of transplant, we see this risk. And so we really do focus a lot on blood pressures, especially for hospitalized patients. And if you transfuse someone too much, which of course, if you can imagine, right, you increase more fluid into the system, it's going to increase the blood pressure. That can actually cause this as well. And so there have been some reports that have shown that people who get too much blood, simple transfusion specifically at a time, are at risk of having a stroke. But when we talked about press, specifically that syndrome I told you about, we saw it far more often in transplant than in non-transplant settings. And it's one of the main reasons we really keep blood pressure control. We keep patients in the hospital for longer, and we keep their platelets higher for a long time post-transplant. Let's see what else. This is just looking at press. This is what it looks like on a scan. You can see it in other settings, but it's this very typical way of this presenting. And again, it often presents with seizure, and everybody worries they had a stroke, but they don't have a stroke. There's no infarct or ischemia to the tissue as long as you control it. And this is just showing you vasogenic edema that's lighting up. All right. So, what do we do then? We really want to control our hypertension emergencies all the time, but especially in the transplant setting, making sure that we use immediate medications. I prefer not to use labetalol in a lot of these settings because I actually find it can be a problem in patients who may become very anemic. And if it's happening in transplant, we sometimes have to hold their anti-rejection medication because we know that that causes hypertension, but we want to get that blood pressure down as fast as possible and make sure that we're not doing it too fast. We actually want to reduce it by about 20 to 25% in the first 2 hours and not any faster. Because again, if you reduce blood pressure too quickly, the brain can't auto-regulate. So when we think about, again, our transplant patients, as you can see, we're very focused on blood pressure. These are just some of the things we do now that really help prevent complications. We determine a baseline blood pressure. We make sure we're staying within that 10% of that area. We're very aggressive in our antihypertensive management. We keep our platelets up and our magnesiums up. The other thing we have to think about when we think about transplant, or really almost anything in sickle cell disease, is that they're at increased risk of having blood clots, and they're hypercoagulable at baseline. And of course, many of you have seen that many of our patients do develop blood clots, whether or not we're even talking about transplant. And there's a lot of reasons for this, and we'll have a separate discussion on blood clots later. But there's overexpression of tissue factor and P-selectin and overall inflammation, and all of this is part of the problem. But a big part of it is the endothelial activation. And, you've heard me say kind of a few times that we see that the blood vessel gets really damaged by sickle cell. And so, it's just like a bad road, right? The more the road is damaged, the more problems on the highway, the more there's wrecks on the highway. Same thing in terms of blood vessels. The more damaged that blood vessel is, the more likely you're going to have a clot or other problems. We'll talk about this more later, but one of the other things we don't do is use what's called GCSF. So in normal transplants, we use GCSF to help stimulate that new bone marrow, and it helps decrease the time in which they have low blood counts. We can't use it in sickle cell because actually it has been reported to cause death in people with sickle cell. And that's because their GCSF, it intentionally stimulates white cell production, which can trigger severe crises. So we now really don't use it unless there is severe risk, like someone becomes highly infected. Otherwise, we don't use it in transplant at all. And then infection is another big risk in stem cell transplant, especially when you get transplant from somebody else. There's a risk of bacterial, fungal, and viral infections. So we actually give them medications for at least the first 100 days that help prevent all of these things. And we monitor weekly for the appearance of yeast or virus, not just HSV, but also CMV. So we now know what we need to treat, and there's better medications even than the last time I wrote this talk.
Do you have penicillin maybe, or what do you give?
No, we give Cipro.
Oh, Cipro for 100 days, okay.
That's the most common. Sometimes we use penicillin, but Cipro is the most common because it has better gram-negative activity.
I didn't hear the question, Dr. Cantor.
Oh, the question was whether we use penicillin for bacterial prophylaxis. And I was saying often we use Cipro. Sometimes we use penicillin, but more often it's a bigger gun that we use for prophylaxis. The other thing that's important that we don't have to deal with a lot on the outpatient side is that after we've transplanted somebody, they have to get irradiated blood, which is a whole nother discussion. Again, most of our patients, by the time they come back to us in the outpatient setting, it's not an issue, but it's important to note because it's different. Most people with sickle cell don't need irradiated blood. So one of the things that we talk a lot about is that stem cell transplant, now that we've refined our processes, is incredibly effective. In young children, it's curative in up to 95% of people if they have a matched donor. As we'll talk more about later, about 10 people, only about 10% have a matched donor. So that really limits availability. And we've really improved the way we do this. We do an exchange transfusion ahead of time. We have better ways of preventing blood clotting. We keep their platelet counts higher. We keep their blood pressures more stable. We no longer use any GCSF. We really watch out for infections, and we've changed our transfusion requirements. And all of these things have led to making stem cell transplant very effective and curative. Unfortunately, just not universal. But it's also a lot of work. These patients are in the hospital for a minimum of 30 days after transplant. If they live further than 20 miles from the hospital, they have to stay locally for a while. So that's a big deal. They have to actually stay in Birmingham for at least 3 months or until we know they're very stable. And then we really continue to monitor their anti-rejection meds, which they may need for at least a year, if not longer. Remembering those anti-rejection meds can cause their own set of problems. Any questions?
What anti-rejection does you use? Transplant, or what do you use?
No,
Tommy had one in chat, Julie.
what?
Tommy had a question that he put in chat.
Oh, that's a great question, Tommy. I'll answer both questions at once. And Karen asked what anti-rejection meds we use. So now we almost always use sirolimus. That's the most common one. We've seen a lot less neurotoxicity with it. And it significantly seems to decrease some of those risks. Anti-seizure meds, they actually stay on as long as they're on those anti-rejection meds. So as long as they're on sirolimus, they stay on Keppra. So that's a significant difference as well. Now, when we start talking about gene therapy, which we'll talk about later, those patients don't need rejection meds because it's their own cells they get back. So they only get anti-rejection meds during the actual chemotherapy. And then they get to stop them. Other questions?
Hi, Dr. Cantor. I have a quick question.
Yes, ma'am.
Sorry. If the matched sibling has like sickle cell trait, do you genotype them first to see if they have trait before you even begin the
Fantastic question, Lauren. So yes, we do electrophoresis normally because that can tell us trait right away, but you can use trait donors. So people who have trait are great donors because sickle cell trait has, at this point in our understanding, no significant clinical complications. All that being said, we do hypothesize that there could be a complication that we're unaware of, which is why we're doing that AUNT study that Lauren is going to get to know incredibly well. But regardless of that, it is important to answer that because a lot of people ask that question. And we have tons of people who get donations from somebody with sickle cell trait and they're fine. Any other questions? All right, guys.
Yes, I'm wondering, my apologies. I'm just wondering, like, how excited were the participants to do these studies, knowing that the risks were so great?
You know, so it's a really good question, Tommy. In the 1990s and early 2000s, the median lifespan for sickle cell disease was still considerably lower than it is now. And the people at highest risk, those with repeated acute chest syndrome or stroke, they were pretty excited, especially those who'd had a stroke. You know, the risk of stroke is pretty terrifying. And so we didn't have some of the capabilities that we have now to prevent stroke. We didn't even routinely use hydroxyurea, right, our main disease modifying medication, until at least early 2000s that it was used routinely, but it wasn't even approved for use until the 90s. So there were very few other options. So this gave people a 75% chance of normal life, and they were willing to take that risk given that the alternative was so poor. But now it's a very different conversation. So now our median lifespan is in the 40s, which is not 100% accurate because there's this huge increased risk of mortality for people in their 20s that then goes away, which we'll talk a lot about more. But as a result of that, it's a much more in-depth conversation. But the other thing, especially for younger kids, is that survival with a transplant is fantastic. It's 95% with a match-related donor. So there are a lot of families who want to do this long before their kids have severe disease, because they're like, especially if they have an affected child already, they know the risks and they want to go ahead and move forward. We've done a couple of studies now, and I'll show you that in the part 2 of discussion of transplant, but that now demonstrate that the older you get, the higher the risks for transplant. So it becomes a more detailed discussion. But we've also increased the number of donors or type of donors that we use, and half match donors are having better and better outcomes. So I think it's always an in-depth discussion. I usually say it takes me at least 10 hours to talk to someone about transplant before we actually get there.
Thank you.
Yeah, you're welcome. Great question. Other questions? Anybody who wants, you know, I have these conversations, I don't know, probably every 2 to 3 weeks with people. So if you ever want to be in on them, just let me know. Sometimes I also do them by telehealth. We have patients who want to come from everywhere to do various studies. So sometimes I do these conversations via telehealth as well. All right, guys. Well, happy Friday. Stay warm. Hopefully, people are going to come to the Christmas party this evening. I guess it's technically a holiday party. If you are brand new to staff, you might not have known about it. So my sincere apologies, because we had to give our RSVPs like 2 weeks ago, which was kind of crazy. It's the whole division. So there's going to be like 300 people there. And it's going to be really cold. So it's at the zoo and outside. So just dress warmly. Normally I have a holiday party of our own, but because I'm moving and my house is in a bit of an uproar, we're going to have to make that a January party once I have furniture and unpacked. So stay tuned for that. It's coming soon. Thanks, everybody.
Thank you.
Yep.